Hey, and welcome back. So today we're going to talk about moderators and mediators and also rational polypharmacy, because that's pretty much the norm in psychopharmacology. So this is based on the Stahl book, Practical Psychopharmacology from 2021. And so chapter 5 is about how and for whom the treatment works. That is the moderators and the mediators. And chapter 6, we're going to talk about how we're going to combine treatment safely and intelligently when one drug is not enough. Now, the main theme in this lecture is going to be what does good psychopharmacology look like? And it's not about memorizing drugs, but it's about understanding context and mechanism and the various trade-offs you're going to make. So we're going to move beyond first line versus second line, and we're going to think towards clinical reasoning under uncertainty. So let me orient you here to these learning objectives, because these are not abstract academic goals. They map directly onto board questions and real prescribing decisions that you're going to make as a psychiatric nurse practitioner. Now, first, you're going to learn to differentiate a moderator from a mediator, and I want you to apply them to a case formulation. And this is really foundational, because moderators tell us for whom a treatment is more or less likely to work. And a mediator is going to tell us how a treatment produces change once it does work. So if you confuse these, you're going to misunderstand both research findings and patient response. Second, we're going to focus on confounders, interactions, and collinearity, and as that relates to psychiatric research. And this matters because much of psychiatry looks messy, not because treatments don't work, but because studies fail to control for real-world complexity. You'll remember the last lecture we talked about the difference between efficacy and effectiveness. Now, the real-world complexity that these studies are not accounting for are things like comorbidity, adherence, substance use, illness, chronicity. So if you don't understand these concepts, you can't critically read the literature or explain why a trial of medication has failed. And third, we're going to translate pharmacokinetics and pharmacodynamic principles into dose selection and adjustment. And this is where many clinicians unintentionally wind up harming patients, either by underdosing out of fear or by ignoring metabolism interactions and receptor effects. Now, dose is not a number. Dose is a biological negotiation between the drug and the patient. And the fourth thing we'll talk about is how to recognize and manage serotonin syndrome and akathisia. These are not rare trivia questions. These are iatrogenic emergencies that arise from polypharmacy in the setting of rapid titration and poor understanding of drug mechanics. So if you miss these two things, it will have real consequences, including things like hospitalization and suicide risk. And then finally, we're going to apply a rational polypharmacy method to learn how to avoid common prescribing traps, and just as importantly, how to deprescribe safely. Adding medications is easy. Removing them requires judgment and courage and good monitoring. Now, one important framing before we move on is that psychiatry is not about curing diseases in the way that antibiotics cure infections. All we're doing is we are mitigating symptoms and reducing risk, and we're creating conditions where a patient can learn to build skills and resilience and capacity. So every intervention is a trade-off, and there are no perfect regimens, only better reasoned ones. So keep that frame in mind as we move through this lecture. Now, when we talk about moderators and mediators, we're really asking a deceptively simple question. What does the same treatment help one patient? Why does that help, and why does it fail another? Now, traditional psychopharmacology teaching often implies that if a medication is evidence-based, it should work for most people most of the time. Well, your clinical experience will quickly teach you that that's not how psychiatry actually behaves. Let's start with this framing statement right here. So matching the right patient to the right treatment at the right time improves outcomes and reduces trial and error, right? So you've heard of the 5 rights of medication. In this case, we need the right patient with the right treatment at the right time in order to reduce our trial and error. Now, this aspiration of modern psychiatry, but it's also a quiet admission of our limitations. We do not yet have perfect precision medicine. What we do have is probability shaping variables, and this is where that concept of moderators and mediators comes into play. So a moderator answers the question, for whom, under what conditions, and does this treatment work better or worse? Moderators exist before treatment starts. They don't change because of the medication. They simply shape how the medication performs. So an example that you are intuitively knowing is age, sex, comorbid anxiety, substance use, trauma history, genetic metabolism differences, illness severity or chronicity. All of those are moderators. If you've ever said SSRI tend to work better for patients like this, you're already thinking about what moderators are going to affect the response, whether you had the language or not, but now you do. A mediator, in contrast, answers a different question. How does the treatment actually produce change once it works? So mediators are sitting in the causal pathway between the intervention and the outcome. Some examples of mediators include things like symptom reduction leading to improved functioning, sleep improvement mediating mood improvement, reduced rumination mediating antidepressant response, therapeutic alliance mediating medication adherence. Mediators change because the treatment is working. So this distinction matters for 3 reasons. First, it improves your clinical reasoning. So instead of saying things like this medicine didn't work, you begin to ask, was this patient a poor match? That is a moderator problem. Or did the mechanism fail to activate? That is a mediator problem. Second, it sharpens your research literacy. Many psychiatric trials fail because they ignore moderators or misidentify a mediator. Now, that doesn't mean the drug is useless. It means the study design was blunt. Third, this reduces mindless trial and error. Now, you may still need to try more than one medication, but your trials become much more intentional and not random. So as we move forward in this chapter, I want you to keep this in mind. You're not just choosing drugs, you're forming a hypothesis about the patient, testing it very carefully, and then you update your reasoning as you learn more. So that's what separates prescribing from clinical psychopharmacology. Well, what's going on here? Moderators versus mediators. So this slide is here to force precision in your language that is often loosely used. Even in published research, you will find this language is misused. So I'm hoping to clear this up for you. So if you confuse moderators and mediators, you're going to misunderstand both the clinical trials and your own patients. So let me start on the left side here with mediators. A mediator answers the how and the why. This sits on the causal pathway between treatment outcome. You can see that visually here. So you see treatment leading to mediator, leading to outcome. The middle box matters because a mediator changes because the treatment is working. And that change then leads to the outcome that you care about. Now, clinically, this means that the medication triggers some intermediate process, and that process produces symptom improvement or a functional change. The example on this slide is early changes in hedonic capacity, right, mediating antidepressant response. Hedonic capacity is your ability to enjoy things and like things, right? This is translated into clinical language. So if a patient begins to experience interest, pleasure, or emotional reactivity early, that change may be the mechanism through which full antidepressant response eventually occurs. If that mediator never moves, then the downstream outcome usually does not either. Now shift to the right side here of the screen. Moderators. A moderator answers the for whom and under what conditions. So unlike mediators, moderators are not on the causal pathway. They don't explain how the drug works. They explain when and for whom it works better or worse. So visually, the moderator interacts with the relationship between treatment and outcome rather than sitting in between them. So the example here is this baseline severity of depression moderating SSRI response. So this is clinically intuitive. Mild depression often responds differently than, say, severe depression. Chronic illness behaves differently than first episode illness. Comorbid anxiety or trauma can blunt or reshape the response. So those factors do not change because the drug works. They are pre-existent. They're the weather. They're the context of the situation, and they will shape the probability of response. Now here's the critical contrast I want you to remember. Mediators move because treatment works. Moderators shape whether treatment works at all. So if a patient doesn't improve, you should be asking two different questions. Was this patient a poor match for this treatment? Moderator issue. Or did the mechanism fail to engage? Mediator issue. Those are very different clinical problems, and they will lead to very different next steps. One last warning, especially for boards review and journal reading. So researchers often label things incorrectly, it turns out. A variable measured after treatment starts cannot be a true moderator. A baseline characteristic cannot be a mediator. Now, when you understand this slide, you're already reading studies more critically than most clinicians. All right, this slide's about demographics as moderators, not stereotypes, not assumptions, not one-size-fits-all rules. When we use demographics correctly, we're not labeling patients, we're just adjusting probabilities. Demographics shape drug exposure and tolerability and response, often before you write that first prescription. So let's walk through these one at a time. Age. Age is one of the strongest and most reliable moderators in psychopharmacology across the lifespan. So children and adolescents tend to have faster metabolisms, but more labile CNS response. Whereas older adults have reduced hepatic clearance and altered body composition and increased sensitivity to side effects. That stimulant example on the slide is very deliberate here. So a dose that's appropriate in a child can produce hypertension, insomnia, agitation, appetite suppression, and weight loss. But in an older adult, the same nominal dose. Age doesn't change how the drug works. It changes how much the drug and the brain actually sees. So the age affects how much drug the brain actually sees and how much side effect burden the patient will tolerate. That's the classic moderator behavior. Sex differences matter even when we wish they didn't. So hormonal milieu, serotonergic tone, dopaminergic signaling, the CYP enzyme activity at different life stages. Women on average show greater SSRI responsiveness, while men may experience different side effect profiles, differential response to certain antidepressant mechanisms. This does not mean you prescribe based on sex alone. It means sex is only one variable that nudges that probability curve. Ignoring it doesn't make prescribing more equitable, it just makes it less precise. Now, race and ethnicity. This is the most sensitive and most misunderstood category on the slide. Race itself is not biological, but ancestry does correlate with genetic polymorphisms, particularly the CYP450 enzymes. So that's why the slide explicitly references a genetic polymorphism, not race as a causal factor. Now, these differences can meaningfully affect antipsychotic serum levels, SSRI exposure, risk of side effects versus non-response. Two patients on the same dose can have 2 to 3-fold difference in the effective response and exposure. So this is not theoretical, it's just clinically observable. So this box in the clinical pearl here is doing a lot of work for you, so don't rush past this. The genotype-phenotype metabolism can change dose needs by 2 to 3 folds. So that's why one patient gets EPS on a low dose and another gets no benefit on the standard dose. Family history, ethnicity, and prior medication reactions often give you more useful information, though, than a genetic test, especially early in treatment. Pharmacogenomics can help, but clinical history is still your first and best tool. So demographics are not destiny, they are context. They help you choose where to start, how fast to titrate, what to watch for, when to reconsider your assumptions. That's not bias, that's just taking in the whole picture. All right, so this slide moves us from demographics to illness characteristics themselves as moderators. So in practice, these clinical features often matter more than age or sex because they reflect how the illness is wired and how long it's been active. Now, these are the variables that quietly determine whether the first-line treatment has a realistic chance of success. Early age of onset is one of the strongest predictors of treatment resistance and illness severity across psychiatric disorders. Now, when symptoms begin in childhood or adolescence, several things are usually true. The illness has had more time to entrench. Developmental trajectories have become altered. Comorbidities are more common, and family loading is often stronger. In both major depressive disorder and bipolar disorder, early onset predicts more recurrent episodes, more incomplete remissions, higher need for combination treatment. This doesn't mean treatment won't work. It means expectations need to be recalibrated. Now, chronicity of symptoms is another powerful moderator. This is a condition lasting more than 2 years, and that means it's rarely a simple neurotransmitter deficit, okay? Chronic illness implies neurobiological adaptation, learned coping patterns that reinforce the symptoms, psychosocial sequelae layered onto the original disorder. This is why chronic depression or anxiety often does not respond robustly to things like monotherapy. These patients frequently require augmentation strategies and combination psychopharmacology and therapy added intentionally, not as an afterthought. Failure to recognize chronicity leads clinicians to a cycle through various medications without any real strategy, mistaking biology for non-compliance or them just being a difficult patient. Baseline anxiety is another underappreciated moderator. High anxiety at baseline can blunt antidepressant response. It can also increase side effect sensitivity. It can worsen early activation and dropout rates. So this is why patients with significant anxiety often report the medication made me worse. Early jitteriness, insomnia, or agitation, partial mood response without relief of distress. These patients may just require a slower titration and often parallel psychotherapy. They also might need some targeted anxiolytic strategies rather than repeated antidepressant switches. Now, this clinical pearl here on the side, when someone presents with treatment-resistant depression, the first question is not what drug hasn't been tried. It's when did this start? Early onset, especially before age 18, changes the probability structure of response to standard first-line SSRIs. That doesn't mean SSRIs are wrong. It means they may not be sufficient alone. So the broader lesson here is this. Treatment failure is often predictable in retrospect. Now, when you recognize these moderators up front, you stop blaming the patient and you stop blaming the medication and you start designing treatment plans that match reality. Now we're going to talk about psychosocial contexts as moderators. So up until this point, our moderators have been focused on biology and illness structure. This slide reminds us that people live in context, and those contexts are powerfully shaping treatment response. So if you ignore psychosocial moderators, that doesn't make you more scientific. It might make you less effective and less safe. So the first important psychosocial moderator here is suicide attempts. A prior suicide attempt is one of the strongest predictors of future suicide risk, stronger than diagnosis alone. So when a patient has this history, it immediately changes the treatment frame. You're no longer just treating symptoms, you're actively managing risk, which is going to mean more frequent follow-ups, lower tolerance for partial response, earlier considerations of things like adjunctive or protective agents. This is where medications like lithium and clozapine will often show up. Not because they're first line for everyone, but because evidence for suicide reduction and not just symptom improvement. So this is a moderator in the truest sense. It doesn't change how the drug works, it changes how aggressive and safety focused your strategy has to be now. The other major thing here is ACE scores. Adverse childhood experiences capture developmental trauma, not just past stress. So higher ACE scores are associated with poorer antidepressant response and higher relapse rates. Greater somatic symptom burden, also things like increased sensitivity to side effects. Why? Well, because trauma reshapes the stress response systems and the attachment patterns and the ability to perceive threat. No medication is working in a vacuum against that background. So this is why higher ACE burden often will favor trauma-informed care and pairing intentional psychotherapy with medication combinations. Careful pacing and expectation setting and also prescribing without acknowledging trauma often looks like non-response, but in reality, it's a mechanism mismatch. The other major psychosocial factor that often gets overlooked but is deceptively simple is medication preference. A patient preference, that is to say, if the patient does not believe in or fears or resents a particular medication for whatever reason, it's almost always going to underperform, no matter how elegant that mechanism looks like on paper. Patient preference will affect things like adherence, persistence through the early side effects, willingness to titrate up to a therapeutic dose. It's going to affect their trust in the therapeutic relationship. This is not the same as pandering. This is evidence-based pragmatism. So what you realize is that buy-in is not a soft skill, but more of a treatment amplifier. A drug that the patient understands and agrees with and feels heard about will often outperform a theoretically better drug that they take inconsistently or resentfully. This is especially true in psychiatry, where expectancy effects and alliance and meaning strongly influence the outcome. You'll recall placebo and nocebo effects from our last lecture. Now, the deeper message in all of this is you're not prescribing to brains in isolation. You are prescribing to people with histories and fears and beliefs and risks. So when you incorporate those psychosocial contexts as moderators, you stop fighting with the patient and you start working with the patient. Now, this is the slide where we're going to move into second-order clinical reasoning, and this is the kind that explains why a technically correct treatment still fails. Now, these moderators don't live on your prescription pad or your electronic health record. These live in the biology of the illness and the trajectory that it has already taken. Now, inflammatory markers, this first point reflects a growing and uncomfortable reality in psychiatry. Not all depression is the same biological problem. So elevated CRP and other inflammatory signals are associated with reduced response to standard SSRIs. They're also associated with increased fatigue, anhedonia, psychomotor slowing, and greater medical comorbidity. In these patients, serotonin modulation alone might be insufficient. That doesn't mean we abandon antidepressants, but it does mean we have to consider agents with broader mechanisms. We need to consider augmentation strategies. We really need to focus on sleep and obesity and metabolic health and systemic inflammation. That doesn't negate the psychiatric illness, it just reshapes it. Another factor to look at here is psychological resilience. Now, resilience is not positive thinking. It reflects adaptive coping and flexibility, and the ability to use support effectively. Higher baseline resilience predicts things like faster improvement, better engagement with therapy, lower relapse rates. These patients may do especially well with a psychotherapeutic intervention, sometimes with less pharmacologic intensity as well. So these may be our Buspar and gabapentin players. Resilience doesn't replace the medication, it just amplifies the effect. And remember, we're always aiming for the least amount of most effective medication. Now, illness course and characteristics. This is the final point to look at. Illness course is one of those most underappreciated moderators. Now, two features matter in particular: duration of untreated illness and number of prior episodes. The longer duration of untreated illness, that is DUI, right, means the more entrenched the neural pattern is and the more psychosocial fallout has occurred. And there's a lower likelihood of a full remission with short-term treatment. Multiple episodes predict higher relapse rates, need for maintenance therapy, less tolerance for medication discontinuation experiments. So this is why some patients just need to get better, quote unquote. They need ongoing protection. It's not a matter of just flipping the switch back. They need that ongoing support. Now, the pearl in this slide is this: when standard SSRI trials fail, it may not be because the patient is non-compliant or the diagnosis is wrong, the clinician chose poorly. It may be because the biological context was never addressed. Things like inflammation, illness duration, prior episode burden, all of that's going to change the landscape. So the big picture lesson is this: treatment resistance is often biologically rational, not mysterious. And when you zoom out and consider the full illness context, your next step becomes clearer and much more humane. So let's explain this little law here. Wilder's law explains something that confuses a lot of people. It frustrates clinicians, and this routinely gets misinterpreted in antidepressant trials. Now, severity drives signal. In randomized controlled trials, patients with more severe baseline symptoms show greater separation between active drug and placebo than patients with mild symptoms. That's not a paradox. It's the statistical and clinical reality. So on the left, you're looking at a drug-placebo separation by baseline severity. As baseline severity increases, placebo response stays relatively flat. Active drug response increases substantially. The gap between those two widens in mild depression. Placebo effects are strong, such as expectation, attention, and regression to the mean all playing a role. But in severe depression, placebo has less room to operate, but biology does. And that's where medication signal becomes more visible. So that's why you may have seen SSRI trials that say the SSRI is like M&Ms in mild to moderate depression and really only effective in severe depression. Now, take a look at the right panel here. Now this principle here, the right panel, states that patients with higher baseline symptom severity often demonstrate greater benefit from active treatment than those with milder symptoms. And this is why. Antidepressants look weak in mild depression, yet are clearly effective in severe melancholic and recurrent illness. So this is not evidence that antidepressants are overused in severe illness. It's evidence that they are best studied and best detected there. Now, there are various factors that influence severity. That middle panel ties this slide back to everything you've already learned. So severity is not random. It's shaped by things like early age of onset and chronicity, multiple prior episodes, comorbid anxiety or suicide history, social stressors and barriers to care. In other words, severity reflects cumulative burden, not just symptom count. Now, the bottom box here talks about these clinical implications, and this is where students will often make a dangerous mistake. Severe illness makes clinicians nervous, and nervous clinicians tend to underdose. Wilder's law tells us the opposite approach is needed. In severe cases, you don't want to dilute the treatment. You don't want to rely on subtherapeutic trials, and you don't want to mistake caution for safety. Instead, use evidence-based agents and dose them adequately, and you want to combine treatments when indicated and monitor closely rather than just being timid. Severity is not a reason to retreat, it's a reason to be more decisive and thoughtful. So this Wilder's law reframes how you interpret trial data like treatment resistance, and why some patients clearly benefit while others do not. Now, when severity is high, signal emerges, and when severity is low, noise dominates. And that's the insight that should shape both your reading of the literature and your clinical confidence. Now, up until now, we've been talking about moderators, that is, variables that change for whom and under what conditions a treatment works. Now, this slide is about mediators, and that is what actually carries the effect of treatment forward once the medication's on board. So if moderators set the odds, mediators determine whether the mechanism ever gets a chance to work. For example, adherence is the single most important behavioral mediator in psychiatry. In real-world effectiveness studies, non-adherence routinely will masquerade as treatment resistance. Now, when patients miss doses and stop a drug early due to side effects or take medications inconsistently, the biological mechanism never has a continuous signal to act on. And at that point, the causal chain is broken. Drug, no exposure, bad outcome or failure to outcome. That's not pharmacology failure, that's mediator failure. So before declaring a medication ineffective, you must always ask, was the drug taken? Was it taken long enough? Was it taken at a therapeutic dose? Otherwise, you're troubleshooting a system that was never fully activated. Another thing to consider is these interpersonal and psychosocial disruptors. The second mediator here is environmental. Things like acute life stress, breakup, job loss, housing instability, caregiver crisis. All of that can drown out the biological signal of the medication. So the drug may be working at the synaptic level, but what? Cortisol is high, sleep is disrupted, threat systems are activated, cognitive bandwidth is overwhelmed. In these moments, reduced or delayed response doesn't mean the medication is wrong, it just means the context is dominating the outcome. So this is why timing matters. Sometimes the right intervention is not switching drugs, but stabilizing the environment enough for the medication to express its effect. Now, early changes in hedonic capacity, this is one of the most clinically useful and most undertaught mediators. So early improvement in hedonic capacity is the ability to experience pleasure, interest, motivation. Often that will precede full mood improvement. So patients may say things like, I don't feel happy yet, but coffee tastes good again. Or, I went for a walk without forcing myself. Or, music doesn't feel flat anymore. These aren't trivial comments. They are signal that the reward system is re-engaging, which then will often predict things like better adherence and increased activity and positive feedback loops and higher likelihood of remission. Mood will often follow behaviors, and that's what we call behavioral activation. Not the other way around. In fact, we don't want people waiting to feel to do something before they do it. So here, you need to look for this first domino effect. Early behavior engagement, even small, seemingly insignificant shifts, often will mediate downstream improvement. So if a patient re-engages socially or returns to a hobby or experiences pleasure before mood lifts, what you're watching is the treatment mechanism come online, and that's prognostically powerful. So mediators are where treatment either gains traction or stalls. You can choose the right drug for the right patient, but if adherence, context, and early behavioral shifts aren't present, the outcome is going to be disappointing. So that's why excellent psychopharmacology always includes behavioral inquiry and environmental awareness and attention to early functional changes, not just symptom checklists. Now this slide's about rescuing the failed treatment from misdiagnosis. This is one of the most clinically important slides in the entire deck because it addresses quite an important factor that's often missed in psychiatry. So many medications don't fail because the mechanism is wrong. They fail because the signal never reaches the brain in a stable therapeutic way. So that's the essence of the pharmacology and biological mediation. So pharmacokinetic interactions are the most common hidden mediator of poor response. Also, things like concurrent medications need to be considered here because they can increase drug exposure, decrease drug exposure, or create fluctuating levels that never stabilize. That CYP450 inhibitor like fluoxetine, that can raise serum concentrations dramatically. If they happen to be on an inducer, that can also do the opposite, rendering that medication functionally subtherapeutic. So when this happens, the outcome reflects the delivery, not the efficacy. So that's why side effects at low doses should raise suspicion. And non-response at adequate doses should trigger an interaction review. You're not just prescribing drugs, you're managing systems of metabolism. Another important thing is pregnancy. Now, pregnancy is a textbook example of biological mediation. Hormonal and metabolic changes during pregnancy alter things like absorption, volume distribution, hepatic clearance, renal elimination. A medication that worked well pre-pregnancy may suddenly appear ineffective, not because the illness has worsened, but because drug levels fell. That's not failure, that's physiology. So maintaining therapeutic effect often requires some intentional dosing adjustments paired with some careful risk-benefit discussions and monitoring. So if you ignore this mediator, that will lead to things like undertreatment and unnecessary suffering. Substance misuse. Substance use mediates treatment response through multiple overlapping pathways. For one, it can reduce adherence. It can directly antagonize the pharmacologic effects. It can destabilize mood and sleep. It can increase psychosocial stressors. Things like alcohol, cannabis, stimulants, and sedatives, they all interfere differently. But the common outcome is the same. You're getting a blurred signal. So in these cases, medication changes alone are rarely going to be successful unless the substance use is addressed in parallel. So this is not moral failure, but definitely mechanistic interference. Now take a look here at the right side this mechanism check. So this box is the clinical reflex that I want you to develop. Now when a patient fails a medication, the first question should be, is this a failure of the molecule or a failure of delivery? And delivery includes things like metabolism, drug-drug interactions, physiological state, competing substances. Many cases of so-called treatment resistance dissolve once these mediators are identified and corrected. Pharmacological and biological mediators are invisible unless you actively look for them. So when you do, you stop blaming the patient, you stop over-switching between medications, and you start practicing with precision. So this is where your expertise will show, not in how many drugs you know and memorized, but in how well you understand why a drug did or didn't get the chance to work. Now let's go into the patient's lived mental experience. If moderators shape the odds and behavioral mediators determine engagement, this slide addresses something even more proximal: how the brain's cognitive machinery enables recovery. Mood does not improve in isolation. It improves through changes in attention, planning, motivation, and cognitive bandwidth. Cognitive function improvement is one of the most reliable yet under-monitored mediators of treatment response. Patients may report things like better concentration, clearer thinking, less mental fog, improved ability to follow conversations or tasks. These changes will often occur before the mood lifts. Now, why this matters? Because improved cognition enables adherence, and patients can remember to take meds. They can engage meaningfully in therapy. They can implement coping strategies. So cognition is not downstream of recovery. It's often the bridge to recovery. Another thing to pay attention to here is this executive dysfunction. This is a powerful negative mediator because impairments in planning, initiation, decision-making, working memory, these predict slower and less complete responses, regardless of medication choice. So this is why some patients want to get better but cannot. So follow things that they cannot do would be things like I can't follow treatment plans, attend appointments, complete therapeutic homework, sustain the behavioral change. In these cases, directly targeting cognition through medication choice and psychotherapy and environmental scaffolding, that may be the intervention that unlocks the progress. If executive function doesn't improve, everything else is going to stall. The other thing to note here is substance use interactions. These appear, again, intentionally here because substances don't just interfere pharmacologically, they also impair cognition. So even intermittent use can worsen attention and memory and disrupt the sleep architecture and increase impulsivity and undermine the executive control. So what happens is you've created this compounding mediator effect, which is going to reduce adherence and reduce cognitive capacity and reduce the therapeutic engagement. And that's why it's important to address substance use as a parallel concern. And it's often a prerequisite for cognitive recovery. So don't just ask, how's your mood? You want to ask, how is your concentration? Are decisions easier? Can you follow through better? Cognitive improvement often precedes mood elevation and predicts long-term functional recovery. So if cognition is improving, stay the course. You're going in the right direction, even if the mood hasn't caught up yet. Psychiatric recovery in general is mediated through the person's thinking capacity, not just the emotional relief. So when cognition improves, patients can participate in their own care and treatment can gain momentum and functional recovery becomes possible. When it doesn't, treatment resistance is often misattributed. Expert psychopharmacology watches the brain at work. Don't just check off a mood score and move on. Now, this slide brings everything we've been discussing, moderators, mediators, adherence, context, everything into a single concrete example known as the Katie trial. So if you understand Katie correctly, you understand why efficacy does not equal effectiveness in psychiatry. So Katie stands for the Clinical Antipsychotic Trials of Intervention Effectiveness. And this was not a small or an idealized study. It was about 1,460 patients with chronic schizophrenia, 57 real-world U.S. clinical sites, and the design deliberately compared a first-generation antipsychotic, profenazine, with several second-generation antipsychotics, olanzapine, quetiapine, risperidone, and ziprasidone. And the key question was not which drug works best in perfect conditions. It was how do these medications perform in real clinical life with real patients. Now some key findings here. Look at this right panel here. This is the headline number that you need to remember, and often it's misunderstood. So 74% discontinued their medication before 18 months. Now that number shocks people, but it shouldn't. Patients stop medications for a variety of reasons: insufficient efficacy, side effects, weight gain, sedation, patient choice and preference. Notice what's missing here. There was no single bad drug. What Katie revealed was that real-world moderators and mediators dominate the outcomes. What Katie actually teaches is the lesson line on this slide that's critical. Effectiveness appears lower when moderators like comorbidity and adherence and cognitive impairment and substance use and social instability are ignored or underappreciated. So in tightly controlled efficacy trials, these variables are filtered out. In real life, they are the rule, not the exception. So that's why medications that look similar in the randomized controlled trials behave very differently in practice. That high discontinuation rate does not mean antipsychotics don't work. It means tolerability matters as much as efficacy. And patient preference matters, and cognitive and social support matter, and adherence is fragile. Katie exposed the myth that you can separate pharmacology from the human context. So this is where Katie directly informs your prescribing. You need to measure adherence explicitly, don't assume it. And you need to actively assess moderators like substance use and cognitive support. And you want to prioritize individual tolerability over theoretical superiority. A drug that works best on paper but is discontinued is inferior to a drug that the patient will actually take. That's not a compromise, that's wisdom that you will hopefully develop sooner than later. Katie is not meant to be a pessimistic trial, it's just an honest assessment. It teaches us that psychiatric treatment succeeds not when you chase the strongest drug, but when you match treatment to the patient and you anticipate moderators and you support mediators and you respect the patient experience. This is the bridge between science and practice. Now this is where we step back from clinical intuition and make our thinking explicitly scientific. So every study, every trial, every paper you read or write or rest on a clinical distinction between what is changed and what is measured. Now that's the difference between the independent variable and the dependent variable. So the left side here is the independent variable. The independent variable is the cause. It's the variable that the researcher manipulates or assigns or categorizes intentionally. This is the input into the system. In clinical research, the independent variable is often a medication class, a specific drug, a dose, a treatment condition, an exposure status. The example I give here is this SSRI versus SNRI, or a specific dosage level. So if you can ask, what did the researcher change on purpose? You have found the independent variable. The right panel here is the dependent variable, and that's the effect. It's what changes in response to the independent variable. Now this is the output of the system, what you measure to see whether the intervention mattered. So in psychiatry, the dependent variables are commonly things like symptom severity scores, functional outcomes, time to relapse, response or remission rates. So here in this example, reduction in depression severity measured by a standardized tool like the PHQ-9. So if you can ask, what outcome are we watching to see if the independent variable worked? That's how you've identified the dependent variable. Now this versus in the middle here, this comparison is not about opposition, it's about directionality. So the independent variable flows into the dependent variable. You manipulate the independent variable, you observe the dependent variable. Reversing them is one of the most common errors students make, and one of the fastest ways to misunderstand a study. Take a look at the bottom here. This example at the bottom ties this directly into clinical research logic. So in a study of major depressive disorders, the independent variable was the antidepressant class, and the dependent variable was the PHQ-9 score reduction at 12 weeks. That single sentence contains the entire causal hypothesis. Everything else is moderators, mediators, covariates, and that only makes sense after this relationship is clear. Now, why does this clinically matter? Clinicians often talk as if side effects are outcomes, and adherence is an outcome, and patient preference is an outcome. But in research terms, side effects can be mediators or competing outcomes. Adherence is often a mediator. Preference is often a moderator. So if you don't know what the independent variable and dependent variable, you cannot correctly place anything else into the model. So think of it this way. Independent variable, what you do. Dependent variable, what happens. A clear IV-DV thinking is the backbone of how to read papers intelligently and designing studies responsibly and translating research into practice without confusion. Once that's solid, moderators and mediators stop feeling abstract and start to feel very useful to you. Now, many errors in both research interpretation and clinical reasoning come from confusing confounders with interactions. Now, they look similar on the surface, but they require opposite responses. So let's separate them cleanly. Confounders on the left here is a third variable that is related to both the independent variable, the dependent variable, and in doing so, distorts the apparent relationship between them. So this is why the slide labels confounders as the distorter, or the third variable. A confounder makes a treatment look less effective than it really is, or more effective than it really is, not because the treatment has changed, but because something else is contaminating the signal. So for example, antidepressant plus substance use. In the example shown, substance misuse affects adherence. The independent variable doesn't fully reach the patient. Substance misuse independently worsens the depression outcome, which is the dependent variable. So what's the result? The antidepressant appears ineffective, when in reality, the study is measuring two problems at once. This is not an interaction. This is bias. So what's the clinical action for confounders? When you identify a confounder, the response is you need to control for it, or adjust for it, or stratify it, or exclude it analytically or clinically, because confounders need to be neutralized, not interpreted. Now on the right side there you see interactions. Now an interaction is fundamentally different. Here, the effect of the independent variable on the dependent variable depends on another variable. This is why interactions are labeled the qualifier. It depends. The treatment works, but not equally for everyone. The relationship itself changes based on the context. So this clinical example here, sex times medication type. So in this example, sex modifies how medication type affects symptom reduction. So women may respond better to SSRIs and men may respond better to tricyclics. This doesn't distort the data, it reveals structure in the data. So a confounder, this result is misleading, the interaction. This result is true, but conditional. So confounders threaten validity, and interactions enhance precision. So look at the action box at the bottom of the slide here. They intentionally differ. Confounders identify them and control for them. Interactions, you have to probe them a priori and use them to tailor treatment. So in practice, you're going to remove confounders from your reasoning. You lean into interactions to individualize the care. So why does all this clinically matter? Because mislabeling a confounder as an interaction leads to things like rationalizing bad data, or over-personalizing weak evidence, or mislabeling an interaction as a confounder. That will lead to things like flattened treatment approaches and missed opportunities for precision medicine. So when you become an expert and a careful researcher, you're going to know the difference. The takeaway of all of this is confounders obscure the truth. Interactions refine the truth, and your job is going to be to eliminate the first one and exploit the second one. And that distinction is what's going to separate noise reduction from clinical insight and is going to help when we get to intentional polypharmacy down the road. Now, this slide teaches us to be intellectually humble and to have some restraint. So this slide is about knowing when not to overinterpret data. So in both research and clinical reasoning, one of the most dangerous mistakes is confusing correlation with causation, overlapping predictors with independent effects, signal with artifact. This slide gives you the tools to show you how to ask the question and slow you down to say, what kind of relationship am I actually looking at? Now, the concept of collinearity is saying to you what it is and why it matters. So collinearity occurs when two or more predictor variables are highly correlated with each other. So when this happens, statistical models struggle to separate their individual effects, and estimates become unstable. Small changes in data can flip results. The key issue is not that the variables are meaningless, it's that they are entangled. Collinearity here on the right side of the screen, you have age and chronicity of illness, and these are classic examples. So older patients have lived longer, therefore often have longer illness duration. When both are included in a model, you may not be able to tell whether outcomes are driven by age or by years of untreated illness. That ambiguity is collinearity. Clinically, this reminds us that these factors travel together. They should be interpreted as part of a shared risk profile, not isolated levers. A true relationship reflects the causal or meaningfully predictive connection between variables. So here, the independent variable directly influences the dependent variable. So the example given is intentionally clean. Higher SSRI dose, greater serotonin reuptake inhibition, improved depressive symptoms. This relationship is mechanistically plausible, dose responsive, replicated across studies, and true relationships will withstand adjustments for confounders. They'll withstand sensitivity analysis, clinical scrutiny, and this is what we want our conclusions to look like. Spurious relationships are what we call false signals. They look real, they're statistically significant, they're even compelling, but they arise because of confounding variables and poor study designs and misspecified models. So an example of a spurious relationship is something like insomnia leading to anxiety example is that classic trap. So you might conclude that insomnia causes anxiety. But in reality, both insomnia and anxiety are symptoms of an underlying depressive disorder. So depression is the confounder here. So failing to account for it produces a false causal narrative. So this is how bad conclusions get published and then repeated. So how do you think about these three categories? So the mental sorting rule I want you to internalize is this. Collinearity. These predictors overlap. I must interpret them cautiously. True relationship. This effect persists after adjustment and makes biological sense. Spurious relationship, this disappears once the real driver is accounted for. Each category demands a different response. When you see collinearity, you need to be humble and model discipline. When you see true relationships, you can have confidence and good application. When you have these spurious findings, you need to remain skeptical and correct them. So clinicians will read abstracts and not regression tables. So if you don't understand these distinctions, you're going to overcredit weak findings in the research, and you're going to underappreciate uncertainty, and you're going to apply conclusions too rigidly. So when you become an expert clinician and a scholar, you're not the ones who always have the right answer. You're going to be the ones who know when the data cannot actually answer the question cleanly. Not every association is going to deserve a prescription change, and good science and good medicine requires you to know when variables are tangled and when effects are real and when conclusions are artifacts of poor modeling. And this slide is your guardrail against that false sense of certainty. Now what we're looking here is not standard clinical practice. These are research-grade signals that help us understand why patients respond differently, not yet tools that we're actually using. So the goal of this is not memorization as much as it's meant for a conceptual orientation. So the big picture first is that psychiatry has historically been and continues to be a symptom-based trial and error, population averages applied to individual situation. And biomarkers aim to answer better questions. Which biology is dominant in this patient, and what does that imply for treatment? This table groups biomarkers into three broad domains. We have inflammatory, neurophysiologic, and neuroimaging, and each gives a different lens on treatment response. So the inflammatory markers start here. So because this is where the data are strongest and most disruptive, things like high sensitivity CRP suggests a systemic inflammatory state, depression that may not be serotonin dominant. And studies show that poorer responses to standard antidepressants and better response to anti-inflammatory strategies in some subsets. Now, this doesn't mean we prescribe infliximab for depression. It means that inflammation modifies antidepressant response. Likewise, here, interleukin-6, high IL-6 levels are associated with reduced SSRI efficacy. They're associated also with better response to adjunctive or alternative approaches. So clinically, this helps explain things like fatigue-heavy, anhedonic, somatic depression phenotypes. Again, this is about why the SSRI didn't work, not blaming the patient or prescriber. Tumor necrosis factor and soluble TNF receptor 2, elevated TNF signaling predicts reduced response to standard antidepressants and may correlate better with outcomes using things like ketamine or ECT in severe cases. Well, this reinforces a key principle. Not all treatment resistance is psychological. Some is immunological. Moving on here to neurophysiology. Now, when we shift from inflammation to brain function and regulation, EEG alpha asymmetry. Certain EEG patterns predict better response to SSRIs and to psychotherapy. Well, this supports the idea that baseline cortical activity patterns influence treatment, engagement, and benefit. So where we're seeing brain readiness, not just diagnosis. Another one here is heart rate variability. This is a proxy for the autonomic nervous system's flexibility and ability for stress regulation and capacity. So higher HRV predicts better antidepressant response and better overall treatment engagement. So clinically, this aligns with what you already see. Patients who can regulate physiologically tend to recover faster. Neuroimaging, this is the most sophisticated and least clinically accessible category. PET, anterior cingulate cortex activity, ACC. Higher baseline ACC activity predicts better SSRI response. Now, the ACC is involved in things like emotional regulation, error monitoring, cognitive emotional integration, and this helps explain why some patients click with medications early. functional MRI, you will see things like greater prefrontal and amygdala connectivity. And that predicts things like better psychotherapy response, better SSRI response. So in plain terms, the brain's regulatory circuits are already partially online, and treatment doesn't create regulation from scratch. It's amplifying existing capacity. Now, a note in the footnote really matters here. These are research tools. These are not standard clinical practice. You should not routinely order these. Promise biomarker guided precision psychiatry. Don't do that because it's not ready for prime time. Do not overstate individual predictability. What you should do is understand that heterogeneity in depression is biologically real, and stop assuming that non-response equals non-compliance or difficult patients. The purpose of this slide is to reframe treatment resistance as a signal, not a failure, as a biology mismatch, not a moral failure. Okay, this is for you to reason and to rethink mechanism, not to just simply escalate blindly. Precision psychiatry isn't here yet, but mechanism-informed humility is. So this mindset is available to you right now, even without the biomarkers. Now, this slide is where clinical judgment replaces rote dosing. So this slide separates pharmacokinetics from pharmacodynamics. And that distinction is not just academic. It's the difference between how much drug reaches the target and what the drug does once it gets there. So pharmacokinetics, this is the body acting on the drug. And pharmacodynamics, this is the drug acting on the body. And most prescribing errors come from confusing the two. So pharmacokinetics is body acting on drug. That is to say, pharmacokinetic answers one question. How does this patient handle medication? So this takes into effect things like age. So in older adults, hepatic metabolism slows and renal clearance declines, and volume of the distribution changes. So that's why we do things like start low and go slow, and that actually applies well here. It does not mean stay low indefinitely. And it does not mean avoid therapeutic dosing. And it doesn't mean substitute caution for effectiveness. Pharmacokinetics also account for drug-drug interactions, and so pharmacokinetic mistakes will cause silent failures. So for example, fluoxetine inhibiting the CYP2D6. The result becomes increased tricyclic levels and toxicity occurring then at normal doses. Inducers, on the other hand, like carbamazepine, this may show decreased efficacy of oral contraceptives and antipsychotics. So here, non-response is often pharmacologic sabotage, not treatment resistance. Pharmacodynamics is how the drug works on the body. So pharmacodynamics answers a different question. It says, what does the drug do to the patient over time? And this is where we get into things like tolerance. So some drugs lose effect when repeated exposure occurs. A classic example is benzodiazepine. So initial anxiolysis fades over time, and you need more and more for less and less. And sedation and dependence remain. So that's not patient failure, that's what we're calling tachyphylaxis. Another thing is receptor occupancy. So every drug has a therapeutic window and a target engagement threshold. So off-target liabilities and underdosing can occur, and that often will engage that side effect pathway, and you'll fail to engage a therapeutic one. And that brings us to this pearl. So appeasing patient anguish by underdosing is a common pitfall. So this is one of the most important lessons in psychopharmacology. A subtherapeutic dose carries 100% risk of side effects and 0% benefit of therapy. So patients don't feel safer, they feel disappointed. So the correct strategy is to use slow titration and build trust, and then reduce early side effects while preserving that therapeutic alliance. But you always want to aim for that therapeutic window, or switch agents if tolerability fails. Don't park at an ineffective dose to manage the anxiety, be it yours or the patient's anxiety. Therapeutic alliance is not just pharmacology, it's relationship management. So if a patient cannot tolerate a medication, don't punish them with inefficiency. You don't also want to gaslight them with give it more time. Instead, what you want to do is adjust or switch. And you also want to reframe the expectation quite honestly, because effective dosing is also an ethical obligation. So pharmacokinetics explains the drug's exposure. Pharmacodynamics explains the drug's effect. So good prescribing requires you to master the difference, and clinical wisdom is going to live in the space between these two, so you can distinguish what's going on. So we're moving on, and up until this point we have focused on single agent reasoning, choosing dosing and optimizing one medication at a time, and that's necessary. But often it's not sufficient for real patients, and most patients you're going to treat, especially those with chronic or recurrent or severe illness, will not get better on monotherapy alone. So next we're going to talk about when and how to move beyond that without drifting into careless polypharmacy. So polypharmacy is not inherently bad. Unthinking polypharmacy is bad. Rational polypharmacy is intentional, it's mechanism driven, it's time limited, has to be goal directed, and it has to be actively monitored. So every medication in the regimen needs to earn its place. So your job is to maximize benefit and minimize harm. Well, duh, it sounds obvious, but most harm in psychiatry comes from add-ons without clear targets. It also comes from frequently seen stacking of drugs that do the same thing. And it also comes from failing to reassess legacy medications and treating side effects with more medications instead of fixing the cause. So what I mean by rational polypharmacy, we're capitalizing on complementary mechanisms, not redundancy and not shotgun prescribing. Evidence where it exists and humility where it does not, and also safe monitoring, and that includes labs and vital signs and therapeutic drug monitorings and EKG and metabolic tracking, and not just like vibe prescribing. So if you can't explain why each medication is there, you should not be prescribing it. Patients don't experience medications in isolation. What they experience is that cumulative side effect burden, that drug-drug interaction, that cognitive and metabolic burden, and adherence fatigue. So your job is not to build the most impressive regimen. Your job is to build the simplest regimen that works. So what we're going to do by the end of this chapter is you should be able to justify combination therapy mechanistically. And also you want to distinguish augmentation from noise. And you want to recognize when polypharmacy is helping and when it's just hiding failures. And then we'll also talk about deprescribing with confidence, not fear. And this is not about adding more tools. It's about using fewer tools more intelligently. Now, before we talk about how to do polypharmacy well, we have to be clear about what people mean when they use the word. And one of the reasons polypharmacy is so emotionally charged in psychiatry is that different organizations define it differently. And they're often talking past each other. So the World Health Organization uses a numerical definition, 5 or more medications used concurrently. Now, it's important to note that the definition is value neutral. The World Health Organization is not saying 5 or more is bad. They're just saying once you hit this number, risk rises and scrutiny should increase. So think of this as a screening threshold, not like a moral judgment. American Geriatric Society shifts the focus from number to vulnerability, and their concern is older adults, altered pharmacokinetics, falls, cognitive impairment, adverse drug reactions, and here polypharmacy becomes dangerous, not because of count, but because of a host of factors. So the same regimen in different patient will have a very different risk profile. The Center for Disease Control takes this chronic illness lens, and it frames polypharmacy in the context of long-term disease management and multiple morbidity and real-world complexity. And their concern is cumulative risk over time. And this is where psychiatry often lives. We contend with chronic illness, long treatment timelines, layering decisions made years apart. There's no single bad choice, but there is a risky accumulation that happens over time. The European Society of Clinical Pharmacy says this is the most clinically sharp definition. So polypharmacy becomes problematic when there's no clear indication, or harm outweighs benefit, or medications persist due to inertia. And this is where the phrase prescribing inertia matters. A medication that once made sense can become inappropriate if no one ever reassesses it. Polypharmacy is not a numbers game. There is such a thing as appropriate polypharmacy. For example, post-MI patients, transplant medicine, oncology, severe psychiatric illness. And there's the problematic, polypharmacy. And problematic polypharmacy is defined by things like weak rationale, redundant mechanisms, unchecked side effects, a lack of reassessment. Your job is not to defend or attack polypharmacy. Your job is just to justify every drug every time. Now that we've defined polypharmacy, let's talk about when it's actually indicated and when it's a sign of failure rather than sophistication. So this is one of the most uncomfortable but most common situations in psychiatry. This is an indication without a drug, and that means this condition is real, impairing, and clinically urgent. So there is no FDA-approved medication that cleanly fits a diagnosis. And this is where that rigid algorithmic thinking breaks down. So what this actually means clinically, the absence of an FDA indication does not mean that the patient doesn't need help, that symptoms aren't biological, that medication has no role. It means that the evidence base is incomplete, indirect, or extrapolated. So that forces us to make decisions in uncertainty. So take a look at example number 1. Acute stress disorder. This is a time-limited, symptom-dense, often severe. There is no FDA-approved medication specifically for acute stress disorder. So what happens? Well, off-label use, of course. So we do off-label use for sleep, hyperarousal, and anxiety. Short-term symptom targeting with a clear emphasis on psychotherapy and time course. The key here is restraint and documentation, not pretending the gap doesn't exist. Example 2, substance use disorder, cannabis use disorder, cocaine use disorder. Here, the problem is not a lack of interest. It's a lack of effective pharmacologic signal. So clinicians often have to target things like cravings indirectly, and we have to treat mood and sleep or anxiety symptoms that are often comorbid. And we use medications to support engagement and stability. But no medication should be presented as curative when it is not. Look at this third example. Borderline personality disorder. Now this is the classic teaching example. There is no FDA-approved medication for borderline personality disorder. Yet, medications are commonly used to target things like affective instability and impulsivity and aggression and severe insomnia. Well, this is acceptable only if you are treating symptom domains not the diagnosis. So you avoid polypharmacy creep and you regularly reassess benefit. So medication is adjunctive, not foundational in these cases. Indication without drug often forces clinicians into off-label prescribing. And off-label prescribing is not unethical. Undocumented off-label prescribing is. So you must be explicit about why FDA-approved options are unavailable or insufficient, and what symptom you are targeting, and what success looks like when you will stop the medicine and when you will reassess the medicine's use. So instead of saying, I'm treating borderline personality with this medication, frankly, you don't say I'm treating any disorder with this medication. I would rather you say I'm treating or I'm targeting severe affective lability and insomnia that are interfering with therapy and safety. And that distinction matters clinically, ethically, legally, and reduces the risk of unthinking polypharmacy. So an indication without drug is not the failure of psychiatry. It's a reminder that diagnoses are broader than our formularies. And your responsibility is not to fill every gap with a prescription, but to prescribe deliberately and transparently and with utmost humility. So next we're going to look at the opposite problem, a drug without an indication, which is where polypharmacy becomes really dangerous. So this slide's about errors that masquerade as treatment resistance when the real problem is in the decision making. Now, most drug failures in psychiatry are not mysterious neurobiology, okay? They are selection errors and dosing errors, like wrong drug selection. This is about fit, not potency. A medication can be evidence-based in general and still wrong for this patient. So the classic example is prescribing a benzodiazepine to somebody with an active substance use disorder or prior benzodiazepine dependence or poor impulse control. The drug may work pharmacologically, but it worsens risk and relapse and harm. So selection has to account for past response and comorbidities and abuse potential and illness trajectory. Overdosage and therapeutic duplication is another major problem. This is an error here of redundancy, not insufficiency. So the most common examples here are things like where two drugs with the same mechanism, or exceeding the safe cumulative exposure. Remeron 90 milligrams, I'm looking at you there. Layering without deprescribing. Cross-titrating an antipsychotic and stuck on one and not coming off. These are common psychiatric pitfalls. Another thing you may see is two SSRIs at once. Sertraline with fluoxetine. That's not double efficacy. That's increased risk of serotonin toxicity and syndrome, and leading to side effects and confusion. If you need two drugs, they should have a complementary, not an overlapping mechanism. Another major problem is this subtherapeutic dosage. This is one of the most common and most avoidable errors. A dose that is too low prolongs the suffering and creates a false non-response, and it also then encourages unnecessary polypharmacy. So where do you see this? Low dose antipsychotic for severe acute psychosis with no upward titration, and then it's declared ineffective too early. This isn't treatment resistance, this is under-treatment. Now, pseudo-resistance occurs when the drug is reasonable, the duration is too short, and the dose never reaches therapeutic range. So before declaring failure, we always have to ask, was the dose adequate? Was the trial long enough? Was adherence verified? Adding a second agent before answering those questions is how polypharmacy begins. So the bottom line in all of this is before changing medications, confirm correct drug selection, confirm adequate dosing, confirm adequate duration, confirm adherence. Only then does it make sense to escalate. Next, we're going to examine a drug without indication and where medications persist long after the reason for starting them has disappeared and where rational deprescribing becomes this ethical obligation. Now, this slide addresses the most common reason medications fail in the real world, and it's almost never the molecule. This slide is about false negatives in psychopharmacology. The medication didn't fail, the delivery system failed. Failure to receive the drug or non-adherence means that the patient is not actually getting drug exposure that you think they're getting. This is incredibly common, especially with mood stabilizers. Medications with delayed benefit, drugs that cause early side effects. Classic example would be something like, say, bipolar disorder, where the patient's missing lithium or divalproex doses. The levels never reach that steady state, and then the symptoms persist, and the drug gets labeled ineffective. Now, from the outside, this looks like resistance, but in reality, the brain never saw the medication consistently. Now, what about adverse drug reactions? These are harms that occur at appropriate doses, not overdoses. So a key example of this would be something like akathisia. That's that inner restlessness. Often it's misdiagnosed as anxiety, agitation, and worsening depression. You will see this in things like antipsychotics and some antidepressants. So the danger is that the side effect drives the distress and then the patient stops the medication or becomes non-adherent. And the clinician responds by doing what? Increasing the dose. Well, this escalates the harm, not the benefit. And what about drug-drug interactions? Well, what that does is it increases toxicity and sometimes can reduce efficacy, or it can create entirely new syndromes. Think about when someone doesn't do a washout period of the SSRI and tries to add an MAOI. So there you get life-threatening serotonin syndrome. And it's not subtle. This is like ICU level complication. More subtle interactions are even more common. So when you have a CYP inhibition or induction drug on board, you may notice increased levels and you will mistake it for intolerance. Or decreased levels get mistaken for inefficiency or inefficacy rather. So again, the molecule isn't the problem, it's the context. So you need to always differentiate treatment failure from non-adherence or intolerance before you increase the dose or add a second drug, or before you declare them treatment resistant. You have an obligation to verify, is the patient taking it? Are side effects driving discontinuation? Are interactions altering exposure? If you skip this step, this is how polypharmacy becomes dangerous. So by the way, the only way you can know this is if you have a good therapeutic alliance with the patient and they feel comfortable enough to tell you the truth. So the bottom line is this: when symptoms persist, you need to confirm adherence and then actively screen for side effects and make sure you're reviewing interactions. Only then do you adjust the dose or add an agent. So next we're going to bring all this together by looking at how rational polypharmacy differs from reactive prescribing and how complexity can be ethical when it is intentional and evidence-based and monitored. Now this is one of the highest yield safety slides in this lecture. So everything here answers one core question. And that is, why did this medication suddenly become toxic or suddenly stop working without changing the dose? And the answer is almost always pharmacokinetics, not pharmacodynamics. Now, what pharmacokinetic interactions actually do is they change the drug level, not the drug intent. So inhibitors, drug levels will go up, leading to toxicity. With inducers, drug levels go down and seem to lead to treatment failure. Now, if you miss this, if you mislabel a patient as non-responsive or treatment resistant or unable to tolerate meds, when in reality the dose was wrong for that metabolic context, that's a problem. Inhibitors, on the other hand, slow metabolism. And you'll see higher levels. Inhibition like fluoxetine, paroxetine, This clinical pairing of SSRI and TCA, what happens? Well, the TCA level rises, and that means the QT gets longer, and you get more anticholinergic toxicity and arrhythmia. So the thing to pay attention to is this is not a subtle thing. TCAs become dangerous quickly, and dose reductions or avoidance are often required. If you look at the CYP1A2 inhibition of fluvoxamine, this clinical pairing of fluvoxamine with clozapine or olanzapine, what happens here? You get a dramatic increase in antipsychotic levels. That causes an increased risk for seizures and profound sedation, and also worsening metabolic effects. So this is a classic real-world and board-style question you may encounter. Now take a look here at this glucocorticoid inhibition with valproate. So valproate plus lamotrigine. What happens here? Well, lamotrigine half-life doubles. Well, if you increase that quote-unquote dose of lamotrigine by doubling the half-life, you raise the risk of something like Stevens-Johnson syndrome. So what do? If you're going to use them together, you need to cut that lamotrigine in half by 50%, and that's a non-negotiable. If we move on to the inducers, this faster metabolism, lower levels, now we flip the problem. So inducers don't cause toxicity, they cause failure. So broad CYP450 induction, like carbamazepine, with oral contraceptives, the outcome will be something like reduced contraceptive efficacy leading to unintended pregnancy. This is a medical legal issue, not just pharmacology. So you have to always run a medication reconciliation at your visits to make sure that nothing new has started. Carbamazepine with phenytoin. So this is an inducer plus antipsychotic. And what happens is you get this reduced antipsychotic level. And so you might see breakthrough psychosis. So it's this med stopped working, except it didn't. The metabolism changed. And what about smoking? Now this is extremely important because we don't serve cigarettes in the hospital, right? And patients get therapeutic. So tobacco smoke plus the antipsychotic, well, what happens? That CYP1A2 gets induced and the drug level goes down. And what happens is the patient stops smoking abruptly when hospitalized in jail or in rehab. That clozapine level goes up, they could become toxic. Or how about we get them therapeutic and they're fine, you put them in the community, they start smoking, start inducing the pathway, they're subtherapeutic, become psychotic, and wind up back in the hospital. So what you're looking at here is the red is the inhibitor, that increases the risk of toxicity. The green is the inducer, that increases the risk of failure. So you want to memorize that logic. Always check interactions when adding or removing a drug. If you are stopping a drug, it can be just as dangerous as starting a drug. And the pharmacokinetic interactions explain this, right? You'll see sudden side effects, sudden relapse, and unexplained intolerance, and what you'll call resistance. So the bottom line in all this is when something doesn't make sense clinically, don't blame the patient, don't blame the diagnosis, although do think about it, and don't reflexively just add another drug. You have to ask, did the metabolism change? Because that question is going to prevent harm. Next, we're going to move from interactions to how and when polypharmacy is rational when it crosses the line into avoidable risk. Now this slide is about what drugs do to the body together, not how the body handles the drug. So if pharmacokinetics is about levels, pharmacodynamics is about effects. Now, two drugs can be at perfect doses and still be dangerous or ineffective when combined because their effects have collided. So pharmacodynamic interactions answer this question. When these drugs are both on board, do their effects stack or do they cancel each other out? Now there are two major patterns. You can have additive effects or you can have antagonistic effects. And both can harm patients for very different reasons. So the left side is the additive effects definition. Now, additive effects occur when drugs have similar mechanisms or share overlapping side effect profiles. So the math here is simple. 1 + 1 = 2 or more. And the risk increases exponentially, not necessarily linearly. The clinical example here would be when you mix benzodiazepines with opioids, right? So both drugs depress the central nervous system and suppress respiratory drive and impair consciousness. Together, you get this profound sedation, profound respiratory depression, high overdose and mortality risk, and this combination is so dangerous that it carries a boxed warning. It's a major driver of overdose death. So low doses do not make it safe. This is not prescribing nuance, it's a public health failure point. The right side of the screen is this antagonistic effects definition. So antagonistic effects occur when drugs have opposing physiological action. So one drug blunts or masks the effect of the other. The math here is 1 + -1 = 0. The danger isn't overdose, it's confusion and false reassurance. So the major clinical example here would be a stimulant with benzodiazepine. The methylphenidate increases arousal, the benzodiazepine reduces arousal, and what happens is you get competing signals in the CNS, and the sedation masks stimulant toxicity, and stimulation masks benzodiazepine impairment. So that's your patient who calls up from the door and says, I need my Xanax and I need my Ritalin. So clinical consequences here are the patient, quote, feels balanced, but they're not, and the toxicity can be missed, and the efficacy is reduced, and the dose continues to creep upwards at both ends, and this is how polypharmacy quietly escalates. So the bottom line here is rational drug combinations do not mean more drugs, they mean complementary mechanisms. Non-overlapping toxicity, clear therapeutic targets. So that's why a combination like, say, SSRI and bupropion, or a mood stabilizer antipsychotic, when indicated, can make sense. Not because they add effects, but because they fill different gaps. So before combining medications, you always want to ask, are the effects stacking? Are they canceling? Or are they truly complementary? And if you don't know the answer, then the combination is not rational. It's experimental. Now, we're going to connect this directly to polypharmacy decision-making and how to justify combinations ethically and clinically and defensively. Now, this slide is an example of rational, intentional polypharmacy, not medication stacking. The nickname California rocket fuel refers to a specific, mechanistically coherent antidepressant combination of venlafaxine and mirtazapine. And this is not causal prescribing, this is deliberate neurobiology. So the left side you have venlafaxine and SNRI. Venlafaxine works primarily by blocking reuptake transporters, and at lower doses it behaves mostly like an SSRI, increases synaptic serotonin at the 5-HT level. At higher doses, norepinephrine reuptake inhibition becomes clinically meaningful, and this is a dose-dependent shift, which is critical. If venlafaxine is underdosed, you're not actually getting the full SNRI effect. You're just running a more complicated SSRI. The bottom line, the bottom left screen here, mirtazapine, this is an NASSA. Mirtazapine works in a completely different way. So instead of blocking reuptake, it blocks presynaptic alpha-2 autoreceptors. This disinhibits norepinephrine release at the serotonin level, and it blocks 5-HT2A and 5-HT2C receptors. Well, this reduces anxiety and improves sleep and lowers sexual side effects. It preferentially shunts serotonin toward 5-HT1A. Now, this receptor most associated with antidepressant efficacy. So the key point in this is mirtazapine doesn't increase serotonin indiscriminately as much as it redirects it. Now on the right side here you'll see that the synergistic effect, and this is where that term rocket fuel comes from and why it matters. So together these drugs increase serotonin availability, increase norepinephrine availability, they enhance downstream signaling efficiency, and reduce common SSRI, SNRI limiting side effects. So this synergy is not addition. We're not doing 1 + 1 = toxicity. We're doing different levers, same therapeutic goal. So why this can work in treatment-resistant depression is this combination simultaneously targets reuptake inhibition, autoreceptor disinhibition, postsynaptic receptor selection, and side effect mitigation. That's 4 distinct mechanisms pushing in the same direction. That's why it has evidence in treatment-resistant depression, not because it's aggressive, but because it's coherent. That being said, you need to be cautious. This is not first line. This is not benign. And this is not a substitute for an adequate monotherapy trial. You must ensure that venlafaxine is adequately dosed. And you need to monitor blood pressure because it can raise it. And you need to watch for sedation and weight gain with the mirtazapine. And you have to reassess regularly for continued necessity. Rational polypharmacy always includes a plan to stop, not just a plan to add. So this slide illustrates for you the difference between random complexity and purposeful design. So when combinations are mechanistically complementary and clinically justified and actively monitored, polypharmacy becomes a tool, not a liability. So next we're going to contrast this with irrational combinations that look sophisticated on paper but collapse under clinical scrutiny. Now this is a diagnosis you need to learn to recognize immediately because missing it can kill a patient. Overcalling it causes chaos, but undercalling this diagnosis is worse. So serotonin syndrome is a toxic state, not a side effect. It's caused by excess serotonergic activity, usually from drug combinations, dose escalations, and interactions. Now this is not subtle and it does not evolve slowly. Onset for this is typically within hours, not days. So you'll notice on the left side here, these 3 clinical domains. Think of serotonin syndrome as a triad, but don't memorize the list, just understand the pattern. Cognitive behavioral, these patients look agitated, confused, hypervigilant, anxious, and sometimes frankly delirious. If the patient looks wired and unsafe, your suspicion should already be rising. Number 2, this autonomic dysregulation. This is where severity declares itself. Things like hyperthermia, tachycardia, hypertension, diaphoresis, mydriasis, flushing, shivering. This is the sympathetic system in overdrive, not anxiety. And number 3 is neuromuscular findings, and this is the most important. This is the diagnostic anchor. You're looking for hyperreflexia, tremor, rigidity, akathisia, clonus, spontaneous, inducible, could be in the eyes as well, ocular. Clonus is the most specific sign of serotonin syndrome. I'll say that again. Clonus is the most specific sign of serotonin syndrome. If you remember one thing from this slide, remember clonus. Now, on the right side here, you'll see Hunter toxicity criteria. Now, these are the criteria you should actually use in real life, and you don't need all the symptoms. You need a serotonergic agent, meaning they have to be taking something that has this, plus one of the following: spontaneous clonus, inducible clonus and agitation or diaphoresis, ocular clonus and agitation or diaphoresis, tremor plus hyperreflexia, hypertonia plus hyperthermia, ocular or inducible clonus. This is intentionally narrow. The Hunter criteria favors specificity over sensitivity, and that's a good thing. The clinical distinction is you have to distinguish serotonin syndrome from neuroleptic malignant syndrome. Serotonin syndrome comes with hyperreflexia, clonus, rapid onset within hours. Neuroleptic malignant syndrome comes with lead pipe rigidity, bradyreflexia, and slow onset. It takes days for this to develop. So if you confuse these, you'll treat them incorrectly. Serotonin syndrome is usually iatrogenic, and the common triggers are drug combinations like SSRI plus MAOI, or SSRI plus the antibiotic linezolid, or SSRI SNRI plus tramadol. Multiple serotonergic agents layered without any reassessment, and rapid dose escalation. So this is why polypharmacy literacy matters. Serotonin syndrome is fast, dangerous, diagnosed clinically, anchored in clonus. So if a patient on serotonergic drugs is agitated and diaphoretic and hyperreflexic, stop scrolling, examine the legs. Now, we're going to talk about management principles and why simply holding meds is not enough. So, why serotonin syndrome happens? Polypharmacy is the dominant risk, and serotonin syndrome is almost never about one drug at a standard dose. It's about stacking serotonergic effects, often unintentionally. High-risk combinations, as I told you before, are these SSRI, SNRIs plus an MAOI, or an SSRI with a TCA, or an antidepressant with a triptan, maybe for migraine, or an antidepressant with tramadol for pain, or an antidepressant with linezolid like a resistant bug needing the antibiotic, or an antidepressant with dextromethorphan, which can be an over-the-counter med they're using for cough. So serotonin syndrome is usually a systems error, not a single bad prescription. The pharmacokinetic interactions amplify the risk silently, so the CYP inhibition doesn't add serotonin, it prevents the clearance, which is more dangerous. So fluoxetine inhibits the CYP2D6, and tricyclics or venlafaxine levels then rise, and serotonergic tone increases without a dose change, and then toxicity just seems to appear out of nowhere. So this is why patients say things like, nothing changed, and then I got sick. Dose speed also matters, so rapid titration, cross tapers without washouts, or overdose all can overwhelm the compensatory mechanisms and increase neuromuscular toxicity, and it can correlate directly with severity. MAOIs are the classic exam real-world danger here, so the test question board answer is you need a 14-day washout period of the SSRI completely and SNRI before you start the MAOI. Okay, so the big thing to realize here is you do not give antipsychotics when you have this situation. This is where you're going to get burned. Why Haldol and other dopamine agents are dangerous, and other dopamine blockers are dangerous, is because they worsen the hyperthermia, and they can increase the rigidity, and they can mimic or precipitate neuroleptic malignant syndrome, because they mask the agitation while the muscle activity continues, and then you can set the stage for rhabdomyolysis. So do not rely also on antipyretics, because Tylenol doesn't help, because the fever is not hypothalamically driven, it's driven by that muscle rigidity. The problem is sustained contraction, right? Not the cytokines. So you don't treat serotonin syndrome like sepsis. You treat this like a neuromuscular emergency. So the management protocol is, number one, stop all serotonergic agents, but that often resolves mild cases within 24 hours. But they also need supportive care like cooling, so you have to address the muscle-generated heat, IV fluids to prevent the renal injury from the rhabdomyolysis. This is why aggressive fluids matter, even if the labs are initially normal. You need to contend with the agitation with benzodiazepines like diazepam, lorazepam, and you want to reduce the agitation and decrease that muscle activity and lower the heat production. Do not worsen serotonin signaling. These are first line for a reason. Now, cryoheptadine, this is the targeted antidote, a 5-HT2A antagonist. Oral only. It's an important limitation. Best for moderate to severe cases with persistent symptoms. Cryoheptadine doesn't sedate, it blocks signal. So the big picture here is that serotonin syndrome is not an allergic reaction, it's not an infection, it's not psychosis, it's uncontrolled neuromuscular activation from excessive serotonergic tone. So you treat the muscle, stop the signal, and don't confuse sedation with resolution. Now we're going to talk about akathisia. This is a condition that matters because akathisia is not just restlessness, it's a movement disorder marked by an intense subjective sense of inner agitation paired with this compulsion to move. Think of it as whole body restless leg. Think of it as restless body. Now, patients are not choosing to pace, they just cannot tolerate the stillness. So patients will often say things like, I feel like I'm crawling out of my skin, or I can't sit still, or I'm going to explode. That language matters because that internal torture, not anxiety as we typically think of it. So the objective signs, what you'll see are things like pacing, rocking, constant foot tapping, shifting in the chair, standing up repeatedly during the interview. If you tell them just try to sit still, you've already missed the diagnosis. Now, you need to know that this can be dose dependent. Akathisia is commonly dose related, so the risk increases with the higher doses and the rapid titration. It's more common in the first generation antipsychotics more than the second generation, but it can occur with also SSRIs and SNRIs, especially during the initiation or dose escalation phase. So this is why early follow-up after starting an antidepressant matters. So you start it, bring them back in a week. Don't wait the 3 months that primary care does. And also, akathisia is a major driver of treatment non-adherence. Patients don't stop meds because they're non-compliant. They stop because the medication makes them feel unbearably well, and this is not benign. Akathisia also increases suicide risk, and it can precipitate impulsive self-harm, and it's frequently misdiagnosed as worsening anxiety or agitation. That misdiagnosis leads to the worst possible move, increasing the dose. So akathisia is commonly confused with agitated depression, anxiety exacerbation, restless leg syndrome. But the key distinction here is akathisia is medication-induced inner restlessness that improves with movement but never resolves. So if symptoms started after a dose change, think akathisia first before labeling the patient as anxious, resistant, or unstable. Now, akathisia is not rare, it's not benign, and it's not subtle. And when you know what to look for, the danger in not missing it is entirely in the interpretation. So you start with the risk factors, and the risk rises with higher dose, rapid titration, first generation antipsychotics more than second, but it's not just a schizophrenia problem. Vulnerable populations also include younger patients, women, or anyone with a prior history of akathisia. And remember, this can occur with antidepressants, especially early in treatment. So if akathisia has happened once, it's more likely to happen again. So what do we do about this? Well, the most effective intervention is not adding another drug. It's reducing the dose of the offending agent. And if clinically feasible, lower the dose immediately or switch to an agent with lower EPS burden, such as quetiapine. This is the moment where restraint is your wisdom. The other thing is you have to have some supportive care. You need to name the experience for the patient. Say something like, what you're feeling is real. This is a medication side effect. It is reversible most of the time. Patients often fear they're becoming more anxious or more psychotic or losing control. So reassurance here is not cosmetic. It directly improves adherence and safety. Now we have to move to pharmacologic interventions because they're going to want you to do something and it helps. So beta blockers are first line, especially propranolol, has the strongest evidence base. They reduce both the subjective inner distress and that observable motor restlessness. So this is your go-to. Also, adjunctive options like benzodiazepines, like clonazepam, can help, but note, they treat the distress but not the underlying mechanism, so it's useful but not definitive. Anticholinergics like benztropine can help in antipsychotic-induced cases, but it's less effective for akathisia for rigidity or dystonia, so don't reflexively reach for it. Low-dose mirtazapine may help, particularly in antidepressant-induced akathisia, likely a 5-HT2 antagonism. This is thoughtful, but it's not a first reflex. Also, akathisia is best treated by recognizing it early and reducing the offending exposure and targeting the physiology, not just sedating the patient. So if a patient says, I feel worse since the dose went up, the correct response is not reassurance alone, it's reassessment. So deprescribing is not inaction. It's active clinical judgment, and it often requires more courage to do this than adding on a medication. What stops clinicians is rarely a lack of knowledge, but it's a cognitive bias we tend to have. So the first thing is, this first misconception is a misperception of stability. So you'll hear this phrase constantly. They seem stable. But stability is not the same as benefit. A patient can look stable while enduring side effects or experiencing emotional blunting or deriving no ongoing therapeutic gain. Or having a superficial calm is not evidence of efficacy, but people like calm, sedate people. So you ask yourself, stable compared to what and at what cost? The other thing is, there is this fear of decompensation. This is the belief that if I stop it, things will get worse, even when there's no clear evidence that the drug is helping and no temporal relationship between starting the drug and improvement. This is loss aversion in clinical form. So we fear what might happen more than we evaluate what is happening. But keeping an ineffective drug just in case is still a decision with risks. So now we have to address the hope of additive effects, and this is where polypharmacy quietly grows. The fantasy is that we say 1 + 1 = 3, when really it's often just like 1 + 1 = 1.5 with double the side effects. Synergy is uncommon and additive toxicity is not. It's more common. So hope is not a prescribing strategy, contrary to what may has ensued. So we need to tackle this disbelief in tachyphylaxis. So many clinicians struggle to accept that a medication that once worked may no longer be working. Tolerance happens. I'm going to put that on a t-shirt. Poop out effect may occur. Neurobiology adapts. Continuing a medication indefinitely because it once helped is not evidence-based. It's historical attachment. There's also this habitual renewal and covering our bases narrative that seems to occur. This autopilot medicine that is more common than you would imagine. Refills just get refilled and renewed when the request pops up on the EHR, without ever revisiting the indication, without reassessing outcomes, without asking whether the diagnosis even still applies. Sometimes medications are kept to cover possibilities rather than realities, and then you get uncertainty-bred inertia. Now land this situation. Don't just do something, stand there. This is about action bias versus omission bias. Clinicians often feel safer doing, that is, adding, adjusting, layering, than they do removing. But retaining unnecessary medication is not neutral. It's an active choice with cumulative risk over time. So every medication should be able to answer 3 questions. Number 1, why was this started? Number 2, is that reason still valid? And number 3, is it working now? If you can't answer all 3 questions, the medication deserves a trial of reassessment, not blind loyalty. Now, polypharmacy almost never starts with bad intentions. Sometimes it does start out of laziness. It starts with time pressure, symptom urgency, and misread signals often. And this slide shows you 2 of the most common pathways by which otherwise careful clinicians tend to drift into complex, risky regimens. So the left side has incomplete cross-tapering. Now let's start here. So this is a pharmacokinetic problem, not a diagnostic one. Most psychiatric medications do not leave the body quickly. And as a rule of thumb, it takes about 5 to 6 half-lives for a drug to be meaningfully cleared. So if you start a new medication before the first one has cleared, you're no longer doing sequential treatment, you're doing this unplanned combination therapy. So that danger is not theoretical. Residual drug levels are still active, and enzyme inhibition or induction is still happening, and side effects and interactions are still in play. Fluoxetine is the classic trap. With such a long half-life and an active metabolite, it can take 3 or 4 weeks to clear something like fluoxetine. So if you start a TCA or an MAOI or even another serotonergic agent too soon, it can lead to toxicity, not treatment resistant. Apparent non-response during cross-taper is often due to pharmacological overlap, not failure. The right side of this thing talks about the prescribing cascade. This is not a pharmacokinetics problem. This is a cognitive and systems problem. This cascade usually starts with a partial response or a side effect. So instead of asking, is this dose optimized? Is this the right drug? Is this a predictable side effect? We jump to add something. The sequence is subtle but deadly. So partial response or side effect can be misinterpreted as worsening or a new condition. So then a second drug is added, and new interactions or side effects then emerge. And now you're treating the treatment. At that point, the original signal is lost in all the noise. So think of adding aripiprazole for risperidone-induced prolactin elevation, which is commonly done, unfortunately, instead of switching agents. Or adding a hypnotic for SSRI-induced insomnia, instead of just adjusting the dose or the timing or your choice of drug. Each step feels reasonable in isolation, but together they create this medication inertia. So what ties both of these sides together? Well, both pathways share the same underlying error. It's a failure to pause before adding. So whether it's incomplete clearance or misinterpreted symptoms, the fix is the same. Slow down. Clarify what you're seeing. Optimize before you add. Polypharmacy is often the result of speed, not complexity. Remember, these psychiatric problems did not develop overnight. They develop over months to years. So pump the brakes. So before adding a drug, always ask, has the current drug fully cleared or fully declared itself? Am I treating a disease or disorder situation, or am I treating a side effect? Would subtraction of a drug give me more information than adding another drug? So now we're going to talk about the basics of deprescribing. And I want to reset how you think about it. So deprescribing is not active, it's not giving up, and it's absolutely not the opposite of good care. Deprescribing is active clinical reasoning. So the first principle here is you want to evaluate the medication purpose. Start with the most basic questions that we often forget to ask. Why is this medication here? Every drug should have a clear indication and a measurable target and an observable benefit. So if the symptom is still present despite an adequate trial, then the medication is either ineffective, treating the wrong target, or no longer necessary. And continuing it just in case is not neutral. It's compounding risk. The second principle here is remove one variable at a time. This is critical. When you stop multiple medications at once, you lose information. By tapering one drug at a time, you can attribute improvement or worsening correctly. So you want to identify withdrawal also versus relapse when you do this. So you have to persevere and preserve the patient trust during this process. So think a little scientifically. Change only one variable. Observe the system, make sure it's in the right time frame, and that's how you're going to maintain some clarity during this process. The third principle is to slow tapers and think about thoughtful cross-titration. So abrupt discontinuation is one of the most common causes of rebound symptoms or withdrawal symptoms. And that will erode patient confidence in you. So slow tapers are not weakness. That's how you do this precisely. Now, some medications you can go faster than others. And when switching agents, you have to respect the drug's individual half-life and receptor adaptation and delayed effects. Cross-titration is not a shortcut, it's a safety strategy. The fourth principle I want you to pay attention to with deprescribing is to ensure the drug truly failed before you declare a medication ineffective. You had to have verified, was the dose therapeutic, was the duration adequate, and was adherence confirmed. Many drugs are labeled failures when they were never truly tried. So deprescribing should never punish a drug for our own underdosing or impatience. Deprescribing is an active process. It's not just stopping meds. It requires you to monitor, document, do patient education, and have some clinical courage. The question you should always ask yourself is this medication still serving a clear and current purpose? And if the answer is unclear, that's your signal to reassess, not add another drug. So good prescribing adds medications with intention. Good deprescribing removes them with the same level of attention. Now this slide is here to make a very specific point, and that is that not all polypharmacy is bad, but all polypharmacy must be justified. Now what separates thoughtful augmentation from sloppy prescribing is whether you can clearly articulate. Articulate what? The target symptom, the mechanism, and why this is better than simply adding another drug reflexively. Now take a look at the left side of the screen here. We have Parkinson's symptoms, and we're choosing an alternative. So let's start with an antipsychotic-induced Parkinson's, right? The default response with many clinicians may be to reach for benztropine. And benztropine works, but it comes at a cost. Like what? Dry mouth, constipation, urinary retention, and importantly, it comes with cognitive dulling. And that cognitive burden matters in older adults and in patients with baseline cognitive vulnerability, or in patients already on multiple anticholinergics. So this is where amantadine can become a thoughtful alternative. Amantadine enhances dopaminergic tone, has NMDA antagonism, and it offers comparable efficacy for EPS with less anticholinergic load. So the clinical advantage here is not potency, it's cognitive sparing. Now this is the classic example of substituting smarter, not simply just adding more. On the right side of the screen here, you see treatment-resistant schizophrenia, true augmentation. Now let's be clear. This right-hand example is not routine practice. This is specialist-level augmentation, and it should raise your internal caution flag immediately. So the scenario here is a patient with stabilized positive symptoms on haloperidol, but persistent negative symptoms with anhedonia, withdrawal, flat affect, and the rationale hinges on pathway specificity. So the D2 blockade helps positive symptoms. Negative symptoms may reflect dopaminergic deficit in other circuits. So pramipexole, a D2-D3 agonist, is being used not to undo antipsychotic treatment, but to modulate dopamine signaling in a targeted way. Now this is why the slide explicitly says in stabilized patients. And this is why the caution box matters so much. Anytime you combine a dopamine agonist with a dopamine antagonist, you're walking a very tight clinical line. You have to monitor for reemergence of hallucinations, delusions, impulse control problems. And if you cannot monitor them closely, you should not attempt this strategy. This augmentation with a theoretical and mechanistic rationale, not a causal add-on. So the point of this slide is not to memorize these combinations. The point is to learn how to think like a prescriber who understands trade-offs. Ask yourself, is this an alternative that reduces harm? Or is this augmentation that addresses a clearly defined unmet need? And do I understand what I'm risking by doing this? If you can't explain why a combination exists, you probably shouldn't be using it. Now, if you remember nothing else from today, remember these three pillars. Every defensible case of polypharmacy stands on them. If even one pillar is missing, you should feel uneasy. So pillar number one, complementary mechanisms. First, complementary mechanisms means that each drug must be doing something meaningfully different. We are not stacking medication just because they're from a different brand family. We're not targeting different pharmacodynamic pathways. That's what we should be doing. We should be targeting those different pathways. 2 SSRIs is not polypharmacy. That's therapeutic duplication. A rational combination answers the question, what is this second drug doing that the first one fundamentally cannot do on its own? And if you can't answer that clearly, stop there. The second pillar is empirical precedent. Theory alone is not enough. Just because two mechanisms sound synergistic, it doesn't mean they work together safely or effectively in real patients. So this is why combinations like lithium plus an antipsychotic in mania, say clozapine augmentation in schizophrenia, carry more legitimacy. They are supported by clinical trials and real-world data, not just receptor diagrams. Be cautious of combinations justified only in theory this should help. Or in theory is how patients end up on 5 medications with marginal benefit and real harm. The third pillar is the safety profile, and this is where most prescribing errors happen. So polypharmacy is not just about additive benefit. It's additive risk as well, and you have to actively assess for CYP450 interactions and cumulative anticholinergic burden and metabolic load and QTC prolongation. And this assessment doesn't happen once, it happens every time something is added. So if you're not explicitly thinking about safety interactions, you're not practicing rational polypharmacy, you're gambling. So you need to think about this in your head every time you're tempted to add a drug. Optimize the first drug before adding a second. Most polypharmacy isn't intentional, it's accidental, and it happens when the first drug was never fully optimized. The dose was never pushed, the trial was never long enough, and instead of fixing that, we add something else. That's not strategy, that's just accumulation. Rational polypharmacy is about being precise. It's a calculated intervention to address residual symptoms, not a graveyard of partially effective treatments where we're afraid to stop them. Anytime you see a medication list longer than 2 or 3 agents, ask yourself, are the mechanisms complementary? Is there empirical support? And does the safety profile still make sense for this patient? Because if the answer is not yes to all 3, then the most rational move may not be adding anything at all. Now, drug combinations may be used to enhance efficacy or address partial response, but each carries a predictable pharmacokinetic and pharmacodynamic risk. Now, the clinical task is to intentionally trade risks for benefits, not accumulate side effects inadvertently. So, for example, clozapine plus fluvoxamine or fluoxetine, that's an antipsychotic plus an SSRI. So why do we combine them? Because strong CYP1A2 inhibition increases clozapine plasma levels. It's useful in rapid metabolizers or smokers with subtherapeutic response. It can improve efficacy without escalating the clozapine dose. The risk, of course, is clozapine toxicity can lead to seizures and severe sedation and saluria and agranulocytosis, and it requires frequent clozapine level monitoring, and dose reduction will usually be necessary. What about olanzapine with fluvoxamine, an antipsychotic with an SSRI? Why? Well, a CYP1A2 inhibition increases olanzapine exposure. This is a strategy for the treatment resistance before clozapine initiation. The risk, of course, is increased sedation and metabolic burden and weight gain and insulin resistance and dyslipidemia, etc. There's also enhanced anticholinergic effects, so you have to watch out for constipation and urinary retention. And what about divalproex plus sertraline? That is a mood stabilizer plus an SSRI. Well, divalproex stabilizes mood while SSRI targets the depressive symptoms. It's useful in bipolar depression when antidepressant monotherapy carries that switch risk or that activation risk. Serotonin syndrome, while rare, is possible here. So there might be also increased sedation and gastrointestinal effects. So while you're going to do this, you need to monitor LFTs and platelets. If there's alteration in mental status, add on the ammonia level. So the main thing to keep in mind here is that CYP inhibition can be used intentionally, but must be monitored because pharmacokinetic boosting increases both efficacy and toxicity. And combination therapy magnifies the importance of slow titration and close follow-up. So start low, go slow applies doubly when you're combining medications. So now here are some drug-drug combinations, advantages, and risks. So carbamazepine plus any drug. There is no meaningful synergistic advantage because it's a so potent CYP enzyme inducer of 3A4, 1A2, and 2C. So this combo reduces efficacy of many agents, including oral contraceptives, antipsychotics, and SSRIs. It also increases toxicity risk for drugs with narrow therapeutic indices. So generally, you should avoid combining carbamazepine with any drug unless there are no alternatives. Lamotrigine and divalproex. Now this is true pharmacokinetic synergy. Divalproex inhibits lamotrigine metabolism, and it allows you to use lower lamotrigine doses with improved mood stabilization. This is evidence-based for bipolar disorder. High risk, though, occurs for Stevens-Johnson syndrome if you titrate too quickly, and this requires strict adherence to slow titration schedules. What about tamoxifen with a CYP2D6 inhibitor like fluoxetine? Well, there is no clinical benefit here. A CYP2D6 inhibition blocks the conversion to active tamoxifen. So that reduced breast cancer treatment efficacy. So this combination should be avoided in someone that needs tamoxifen for breast cancer. What about dextromethorphan and bupropion? This NMDA receptor modulation may augment antidepressant effects. Mechanistic rationale for this treatment is for treatment-resistant depression. The danger, of course, is that it increases seizure risk. Bupropion lowers that threshold. There's also an increased risk of serotonin syndrome if combined with other serotonergic agents. Well, what about clozapine and ciprofloxacin or erythromycin? Well, CYP inhibition can raise the clozapine level in subtherapeutic patients. Rare, cautious use. The problem is high risk of clozapine toxicity and sedation and seizures and agranulocytosis. So this will require a dose reduction and frequent serum level monitoring. So you should be in good communication with primary care if they're going to prescribe this to somebody. Now, lithium and divalproex, this is a gold standard combination for bipolar mania and maintenance. It reduces relapse risk in treatment-resistant cases. There is additive tremor, sedation, and weight gain. So you want to monitor renal and thyroid function when you do this combination. And you want to also monitor hepatic function and platelets because of the divalproex. Another combination here is mirtazapine and another antidepressant trying to capitalize on that California rocket fuel. This augmentation for treatment-resistant depression. You can improve sleep and appetite while enhancing that antidepressant response. Again, be careful for serotonin syndrome risk and significant sedation and weight gain. How about bupropion and another antidepressant? Well, this can enhance energy and motivation and mitigates SSRI-induced sexual dysfunctions. Now, this is dose-dependent, so seizure risk needs to be considered, and it may worsen anxiety when you add in that bupropion or insomnia. Now, some combinations are strategic and evidence-based, and others offer no benefit with substantial risk. So pharmacokinetic interactions can help or harm. Intentionality and monitoring are decisive here. Now, before adding a medication, ask whether one agent can address multiple symptom domains. This is a strategy to reduce polypharmacy and interaction risk and cumulative side effect burden. There are some key patterns to recognize with respect to mood stabilizers as symptom modulators, like carbamazepine, oxycarbamazepine. This is strong for mania and impulsivity and aggression. It's useful also for neuropathic pain and migraine and limited antidepressant effect, and there is a significant CYP induction, especially with carbamazepine. Divalproic acid offers broad coverage for mania, anxiety, impulsivity, affective instability, and it can be helpful for migraine prophylaxis and insomnia. There is some limited use for chronic neuropathic pain. What about lithium? Well, lithium is the core agent for mania, depression, impulsivity, and aggression. It's limited utility for anxiety, pain, and sleep. There are some anti-suicidal benefits not shown in the table, but they're critical to consider. Glutamate calcium channel modulators like gabapentin and pregabalin. These are strong for anxiety, neuropathic pain, trauma-related arousal, insomnia. There's some limited mood stabilizing and antidepressant effects, and not really good for anti-mania. Topiramate, broad behavioral effects for impulsivity, aggression, affective instability, strong for migraine and neuropain and binge eating, but limited antidepressant and anti-manic efficacy, and one of the biggest complaints is the cognitive side effects. What about the serotonin modulating mood stabilizer lamotrigine? This is best for bipolar depression, anxiety, affective instability. There's limited use for acute mania and aggression, minimal benefit to none for migraine and pain and sleep. Now, let's talk about deprescribing. If a patient is on a mood stabilizer plus a migraine agent, or a mood stabilizer plus an anxiolytic, or a mood stabilizer plus a sleep aid, reassess whether a single agent already covers both those targets. Rational prescribing starts by maximizing one medication full therapeutic footprint before layering on additional drugs. Most polypharmacy begins when clinicians underuse the breadth of agents that they're already prescribed. Now, this slide reframes antidepressant selection away from diagnosis labels and towards symptom domains. The question is not which antidepressant treats depression, because almost all of them do. The real question is which antidepressant best matches this patient's symptom cluster. So we start here on the left column. The agent then, and then you read across by symptoms. So green means it's reliable and beneficial. Limited means mixed, modest, or patient-specific effects. And red means this drug generally does not help that domain and may worsen it. So look at bupropion, for example, strong for depression, energy, motivation, and attention, and weight neutrality or loss. And it's got limited use for anxiety and affective instability. It's not helpful for pain, trauma, or arousal, migraine, or insomnia. And it may worsen sleep or anxiety early on. So this is an activating antidepressant. If you look at the SSRIs, escitalopram, sertraline there, broad coverage for depression, anxiety, affective instability, hostility, trauma-related symptoms, limited for attention and insomnia, no benefit for neuropathic pain or migraine, and these are your emotional regulation antidepressants. Fluoxetine is similar to the other SSRIs, but more activating, helpful for depression, anxiety, affective instability, trauma, arousal. Limited for sleep, it's neutral for weight, and has a very long half-life, which matters for interactions and tapering, but could be beneficial in your inconsistent taker or someone that is likely to abruptly stop because you won't have the withdrawal syndrome. SNRIs like venlafaxine and duloxetine, one of the broadest profiles that covers depression, anxiety, impulsivity, and affective instability, and it uniquely has an indication for neuropathic pain and migraine. It's limited for insomnia, and this is often a good choice when mood and pain overlap. The tricyclic antidepressants are effective for depression, neuropathic pain, migraine, and insomnia, but it's limited for anxiety and emotional instability. The big danger, of course, is weight gain and anticholinergic burden and QTC prolongation, and these are symptom-powerful but side effect-heavy agents. Mirtazapine is strong for depression, anxiety, and affective instability, trauma, arousal, and insomnia. It's not helpful for pain or migraine. The weight gain is expected and sometimes used accordingly. This is a sedating, calming antidepressant. Nefazodone, this is helpful for depression, anxiety, trauma symptoms, and insomnia with weight neutrality. It's limited elsewhere, rarely used due to hepatotoxicity and concerns, but pharmacologically it's instructive. We have vilazodone here, which covers depression, anxiety, impulsivity, and attention better than classic SSRIs. It's limited for sleep and pain, and often better tolerated sexually. Vortioxetine, this is broad cognitive emotional profile. So depression, anxiety, impulsivity, affective instability, hostility, and attention, but limited for sleep and pain. It's designed to target cognitive and executive symptoms in depression. The main takeaway here is this table is about economizing drug choices. So before adding a second medication, ask whether a different antidepressant could cover multiple symptom domains more efficiently. Good prescribing reduces symptoms. Great prescribing reduces unnecessary medications. Now this slide applies the same domain-based logic to antipsychotics. Again, the question is not which antipsychotic treats psychosis. They all do. The real question is which antipsychotic best matches the non-psychotic symptom profile driving the impairment. So again, you look at this table horizontally, not vertically, and the green means it's reliable and limited means modest, and the dash means no meaningful role. So aripiprazole, broadly activating, strong for psychosis, mania, depression, impulsivity, affective instability, and attention. However, it's limited for insomnia and aggression, and often worsens akathisia, it's the worst offender, and anxiety early on. So think dopamine stabilizer here. Asenapine is a strong medication for mania, psychosis, affective instability, hostility and aggression, and trauma arousal. It's limited for anxiety and cognition. It's useful in irritable, aggressive, and bipolar presentations. Brexpiprazole is similar to aripiprazole but calmer. It's good for depression, augmentation, affective instability, impulsivity, and attention. There's less associated akathisia than aripiprazole, and it's often better tolerated emotionally. Cariprazine, this targets negative symptoms, motivation, and cognition, strong for psychosis, mania, impulsivity, and affective instability. It's limited for anxiety and insomnia. Think D3 forward agent for disengaged patients. Iloperidone is a narrow profile. It's effective for psychosis and affective instability, but limited elsewhere. It requires slow titration, and it's less commonly used. Lurasidone is one of the strongest for bipolar depression with psychosis coverage. It's helpful for anxiety, impulsivity, affective instability, trauma, arousal, attention, and it's neutral for sleep, and it has a low metabolic burden. Olanzapine has very broad symptom coverage for psychosis, mania, anxiety, affective instability, hostility, and insomnia, but it comes at a high metabolic cost. This is a symptom bulldozer. It's effective, but expensive physiologically long term. Quetiapine is excellent for anxiety, insomnia, affective instability, trauma, arousal, and mood symptoms. It's limited for impulsivity and aggression, and it's often chosen for its sedating calming profile rather than its antipsychotic strength. Risperidone is strong for psychosis, mania, impulsivity, hostility, and aggression, and affective instability. It's limited for sleep, trauma symptoms, and cognition, has a higher EPS and prolactin risk profile. The main thing to look at this table is antipsychotics are not interchangeable tools. They are domain targeting agents with different emotional and behavioral, cognitive, and sleep effects. So rational prescribing here means matching the drug to the dominant symptom domain and to avoid stacking antipsychotics to chase side effects. So you want to choose the agent that solves the most problems with the fewest liabilities. You're a trooper for hanging in. Let's hit this case. She's a 42-year-old Hispanic with recurrent major depressive disorder and only a partial response to SSRIs. Now, her symptoms aren't just mood, they're fatigue, anhedonia, poor concentration, and chronic pain. She also has obesity and type 2 diabetes and hypertension and osteoarthritis. So this is not a pick an antidepressant problem. This is a systems problem. Step one is the variables and confounders. So start by separating signal from noise. We have moderators. Who is this patient? We have age that matters, culture that matters, inflammation matters, obesity, osteoarthritis increases inflammatory burden, which can blunt the antidepressant response. We also have things about preference and hesitancy, which will affect her adherence. We have some mediators, so how change happens. Pill burden is real. Early hedonic shifts matter, so watch for worsening anhedonia before PHQ scores move. Now, the independent variables here are medication choice. You have SSRI versus SNRI versus bupropion. The dependent variable here is not just the PHQ-9, but function matters. So we talk about things like pain and energy and concentration. And the confounders in all of this are going to be chronic pain, uncontrolled diabetes, high social stressors. All of that can look like depression even when the medication is working. So if you don't name the confounders, you're going to blame the drug unfairly. So let's optimize the plan. This is the clinical logic here. So step one is optimize before augmenting. Duloxetine makes sense because it targets two drivers at once. It hits the depression and the chronic pain. And this is economizing the drug choice, not polypharmacy. So you start low and titrate thoughtfully. The second step is this rational augmentation only if needed. So if mood improves, but fatigue and inattention and low motivation persist, then we may consider something like bupropion. Why? Because it's got a complementary action, right? We have dopamine and norepinephrine. Minimal sexual side effects, minimal weight burden. It addresses energy and cognition. So this is designed synergy, not stacking. The other thing to think about are the pharmacokinetic and pharmacodynamic safety reality check here. So this is where many clinicians stop thinking. Don't do that. Duloxetine is metabolized through a CYP1A2 and 2D6. She's on metformin, lisinopril, atorvastatin, and naproxen. So there's some key risks here. SNRI plus NSAID increase the risk of bleeding. Hypertension plus NRI, SNRI increase the risk of blood pressure. The diabetes hypertension affects the renal function. So this isn't a contraindication, it's the monitoring plan. So this case shows what rational prescribing actually looks like. You match drugs to symptom domains. You optimize before you add. You name the confounders before declaring a failure. You monitor what matters for this patient, not just the labs. This is not algorithmic medicine. This is the clinical reasoning with guardrails. If you made it this far, you're a super trooper. We're landing the plane. Here we go. So, not with another drug list, but here's the way you're going to think. So you need to recall, we're going to recap it all now. Moderators versus mediators. Remember this distinction. It matters way more than people realize. Moderators answer for whom a treatment works. Age, culture, inflammation, comorbidities, preferences. Mediators explain how it works. Adherence, pill burden, early hedonic indulge, shifts, side effects that derail the benefit. So if you confuse these, you'll mislabel patients as treatment resistant when the issue is actually fit, not failure. Now, research literacy. Clinical trials are not reality. They're controlled approximations of it. So always ask, what confounders are operating here? What interactions are being ignored? Where is the collinearity hiding? Effectiveness studies like CATI remind us that real patients don't behave like study subjects, and neither do their medications. Pharmacokinetics and pharmacodynamic optimization. This is good prescribing, is not about receptors in isolation. It's about using pharmacokinetics to dose intelligently and using pharmacodynamics to select complementary mechanisms. You're not treating serotonin, dopamine, norepinephrine. You are treating a person living in a body with kidneys, a liver, habits, stressors, and limits. Also, you need to remember safety first. Two conditions should now be reflexive for you: serotonin syndrome and akathisia. Both are commonly missed. They're both entirely iatrogenic. They're preventable with better reasoning. So when a patient says, "I feel worse," believe them. Then think pharmacologically. Now, rational deprescribing is when stopping medications is not passive care. Deprescribing is an active intervention. You do one change at a time, slow and deliberate tapers, clear goals and endpoints. Polypharmacy is not failure by definition. Accidental polypharmacy is. The goal of this unit was never to make you more aggressive prescribers. It was to make you more precise clinicians. So you want to always optimize before augmenting. You want to match drugs to symptom domains. You want to name confounders before declaring failure. You want to treat safety as part of efficacy. If you do that, your prescribing will be defensible, humane, and effective, and your patients will feel the difference. So now come prepared to class, because we're going to apply this in real world with case studies.